Good morning, all. Thank you for coming. We have got a very nice this thing. So, for want of time, I think we'll skip most of the slides and we'll go for the video directly. So, managing what do you call this submacular hemorrhage is a real challenge, and with a lot of PCVs coming around nowadays, we used to come across a lot of this submacular hemorrhage. So it is basically the presence of the blood in the potential space between the RP and the neurosensory retina. So we have come across this submacular hemorrhage and the scar in a lot of cases, commonly in AMD or nowadays very common in PCV, high myopia, trauma, everything. And in fact, in case of RAM also we used to come across these things, and very rarely we can have Valsalva, but usually it causes sub-ILM bleed, for which we do a hyalotomy and it clears. Any subretinal hemorrhage has to be evacuated within 24 hours, because otherwise these are the three mechanisms by which the damage starts happening. So when we come across submacular hemorrhage, earlier the intervention, better the outcome. And it's graded based on the size and the thickness into mild, moderate, and severe. But whatever the grade may be, it's better to treat. But prognosticating it depends on these factors. Basically, if the hemorrhage is less than 2 weeks, then the outcome is usually good. But poor prognosis is associated with longer duration hemorrhage, thick hemorrhages, and if it is thick at the fovea. So we have got a lot of options. Most commonly, which we use is the gas and the TPA. So this is a case of traumatic, subretinal hemorrhage. You can find indirect choroidal scar, fortunately temporal to the fovea with hemorrhage. In this case, we have just injected the gas. After the gas injection, over a period of time, you can see the evacuation of the blood and scarring. We can see that choroidal rupture temporally. So patient may not be having good vision, but still retrieving the vision is good. But the surgery is usually fun. I'll skip other surgeries. We'll go for this surgery. Uh, can you reduce the volume? Can you reduce the volume of this? Yeah. Yeah. So recently we came across a case with thick macular scar, submacular scar. The problem with the submacular scar is the scar is usually very thick, chewy. We have tried almost all the instruments. Previously, we used to have 20 gauge. When we operate with the 20 gauge, it was somewhat easy to easy to chew. You can see in the ultrasound there is a vitreous hemorrhage and there is a scar in so it was a planned two-stage surgery, and we have planned for submacular surgery also. You can see the coffee colored blood, and you can see the dense scar under the fovea. So we have to remove this. To do this, we induce the retinal detachment, and retinal detachment is induced by injecting the balanced salt solution filled in a silicone oil injector, mechanized injection. It is more controlled. In 3 or 4 places in the subretinal space, when we inject, the retina detaches. After fluid exchange, once the bubbles coalesce, it's easy for us to do a peripheral retinectomy. So usually we do 180-degree peripheral retinectomy, and with the help of Tanos or Finus loop, whichever we have or whichever we are comfortable with, roll the retina to the nasal side, and we can make out two things in this. One is the submacular hemorrhage was there, that was inferior to the scar, and there was a thick, dense submacular, scar. So we can make out there is a scar under the fovea and the hemorrhage inferior to the scar. So we removed both with the help of the forceps. So we can make out that is a hemorrhage, which can be usually cut with the cutter and removed, but many times the cutter gets clogged. Often we have to clear it, and this is a submacular scar. You can see it's quite dense, chewy, rubbery. So this is very difficult to remove. Sometimes we make a sclerostomy to remove this, but what is happening? So these are all past experiences. We have used cutter, we have used fragmentome, whatnot to remove. So this is some case which was done in the past where I am using the the forceps and then the fragmentome. It was so difficult for us to remove this thing. So finally, after cutting it into multiple pieces, literally it was removed like a foreign body. Sorry for the poor quality. This was done a long time back. So this is another case actually. So what we have done in this case is, after removing the scar, because there was no RP grafting was done. So we can make out the RP graft, which was gently pulled under the fovea. So the graft was placed. Now what to do with this scar? So what we have done in this case, in order to save the time and our mood, everything. So what usually I do nowadays is take the scar. We have done a harvest of RP graft. In that graft area, just put this scar. So if you are not able to remove it, just bury it. So in the area where I have removed the RP for the grafting, in that area, I just keep this scar, then inject PFCL. Okay, so it is a stage surgery, as I was telling. So for next 10 days, this PFCL will be there staying inside the eye. Over that, we top up with the silicone oil. So you can see this is the end of the first stage. So this gives good reattachment of the retina. Once it is done, we go for the second stage. I usually do the laser in the second stage because the coronary retinal adhesion is much easier. So this is the second stage of the same patient, done after 10 days. We have removed the silicone oil, then we have to remove the PFCL also. Once it is done, we go for the laser. So that what you call 180-degree retinectomy, which retinotomy we have done, retinectomy, that has to be treated like a giant retinal tear, and maybe some barraging around the graft also. You can see the scar sitting over the graft area. So we have barraged, and now it is filled with the silicone oil. So once it is done, it is filled with the silicone oil, and there is the graft in the subfoveal area. So usually we use 1000 silicone oil, or sometimes 2000 silicone oil, and the removal is regular. Maybe at the end of third month we remove it. Yeah. So this is 15th post-op day. You can find the graft, and here you can see the scar sitting in the area where we have grafted. So this is one of the newest thing which we have started doing, because removing the scar is very difficult. So we have got all the other options, like you can inject just gas and leave it. Once the blood gets evacuated, we can remove. Or other shortest way is just put this graft under the area where we have harvested. If we have not harvested also, it doesn't matter. Just keep it over the RP and then cover it with the retina and laser it. Never we had any problem so far. So I think with that, I would like to conclude the talk. Thank you very much. Uh, no, this case has got very short follow-up. Maybe around 660 is the vision. Previously, it was hand movements, maybe because of vitreous hemorrhage. But people claim very, tall, in the sense after the RP graft, they get good vision. This is a single-eyed patient. But for a single-eyed patient, 660 is fine. Yeah, fine. But usually they don't go beyond 636, at least in my experience. So,
Like, how do you decide what to do, like plain gas, TPA with gas, or submacular surgery?
now, if there is fluid blood on the retina and the retina is detached, usually what I do is I make a retinotomy peripherally, inject PFCL alone, leave it. So over a period of time in supine position, most of the blood comes into the vitreous cavity, and in fact it fills the AC also. Maybe after 3-4 days, we go inside, remove it, and then go for the gas. If the retina is already detached with subretinal bleed. But in these cases, like wherever there is a scar under the macula, we go for a complete 180-degree retinectomy and removal of the scar. Most of the time, RP graft. And if the scar is very thick, just bury it. Yeah. No, never, never. Because this heavy fluid is so good. It really reattaches. I was telling, like, I do the laser also in the second sitting. Even for giant retinal tear, we do this. At the end of 10th day, we remove the PFCL, laser it, just fill it with the gas and leave it. So it, in fact, one of the advantage of using this PFCL is the retina never slips down.
So after this GRT you created, then you leave in the second stage you put oil or gas?
Second stage, in this case, oil.
Okay.
But in giant retinal tear, per se, gas in the second stage.
Giant retinal tear also I heard that you do in 2 stages, correct?
2 stages.
Yeah,
Most of the cases we do 2 stages.